Great.
Give a short presentation about some of the aspects of the fecal immunochemical test. I've got no declarations. So we're going to try to understand how the test works, how you might use it as a triage tool for patients with symptoms suggestive of bowel cancer, and also as a tool to screen asymptomatic populations. And then just a few tips on how you might use the test to book so that your service runs more efficiently. The test is testing for hemoglobin rather than heme, like the old GIEQ test used to do. And this makes it specific for lower GI bleeding because hemoglobin from the upper GI tract is digested. It's a test with monoclonal antibodies that bind to the alpha and beta subunit of the hemoglobin molecule. And then immunofluorescence is used to quantify how much hemoglobin is in each gram of stool that's being tested. And this gives you very accurate levels of how much hemoglobin is in that sample, and you can use these levels for planning. So my take-home messages are that FIT has excellent negative predictive value, and you can use it as a triage tool to decide which patients need to be investigated. Its positive predictive value is better than symptoms, and you can use that to help manage your unit so that your endoscopist doesn't feel stressed on finding lots of polyps, and your unit is happy because everybody finishes on time because you've planned correctly. Thank you very much.
So why do we tattoo? We want to, localize a specific site in the GI tract, usually the colon, occasionally the small bowel. In the upper GI tract, we rarely, if ever, do this. And the reason we're doing that is because we suspect cancer. It's either we diagnosed it and we want it for surgical intervention, or we suspect the polyp might have cancer, and after we remove the polyp, we want to re-identify the site of that polyp, either for scar assessment or then for further surgical intervention. Now, historically, we've had guidelines which suggested we tattoo things based on size alone, and I think we place many unnecessary tattoos. And some patients are walking about, certainly in Gloucestershire, which their colon more resembles a Dalmatian dog than a normal colon, just because they had lots of polyps, and we tattooed everything over 10 millimeters, and we moved it up to 20 millimeters. And actually, if you follow GIEQs, you realize that, and David is absolutely right, assessment is everything. And I think if you assess the polyp and it's completely benign, there is no reason to put a tattoo in. It's only when there's a suspicion of cancer. And Trevor, I really like the data on double fit, and I appreciate there's a logistic thing and this buy-in from the patients and compliance, but is there a role for the double fit somewhere here to try and, lessen the burden of referral and improve the triaging?
Final questions. I think we could call it a day here. So I'm just going to show you the quiz question. So number B, a single fit has a miss rate of about 25% for screening colorectal cancer, and that is deemed correct. Trevor, do you think that's correct? That is the incorrect answer. So that is, I was reading it wrong. Sorry.
The answer's correct.
The answer's correct. That is the incorrect statement. Yeah. So on that note, sorry, it has been a very long day. I hope you bear with me. So from me, we're going to have a final roundup and goodbye. But from me personally, thank you very much for sticking with us. A big thank you for the guys that have stuck with it today. Again, I think it's a fantastic panel. Again, thanks for Trevor. And I look forward to seeing you all next year for a repeat. So thank you, and have a great weekend.